Hi, everyone. It is my pleasure to share my experience of Doppler ultrasound diagnosis of the Nutcracker phenomenon and syndrome. And specifically, I want to share technical tips and know-how in doing Doppler ultrasound of the Nutcracker. My Nutcracker story begins with this article I wrote in 1996 in Radiology. I had a special interest in the diagnosis of this syndrome with Doppler ultrasound because traditional Nutcracker diagnosis needed invasive catheterization and pressure measurement. Nutcracker syndrome is caused by the compression of the left renal vein between the abdominal aorta and superior mesenteric artery, which causes left renal vein hypertension and may result in hematuria, proteinuria, left flank pain, or various other symptoms or signs. The name of this condition, Nutcracker syndrome, was first used in 1972 by Dr. De Schepper, a Belgian radiologist, describing the similarity of this condition with a nut in the space between two arms of a nutcracker. Historically, in 1970s and 80s, when the ultrasound or CT was not popular, and also regular health checkup was not popular, the diagnosis of the Nutcracker syndrome was done usually in patients with gross hematuria by demonstrating compression of the left renal vein with invasive catheterization and the pressure gradient more than 3 millimeter mercury across the site of compression. We need to be clear in using two different terms, Nutcracker phenomenon and Nutcracker syndrome. Nutcracker phenomenon is just a phenomenon of compression of the left renal vein between the abdominal aorta and superior mesenteric artery, and it is called Nutcracker syndrome when Nutcracker phenomenon is accompanied by otherwise unexplainable symptoms or signs. We use grayscale and color Doppler ultrasound, and we measure flow velocities in the hilar and the aortomesenteric portions of the left renal vein. Normal subtle compression exists in the aortomesenteric portion of the left renal vein, and therefore normal peak flow velocity of the aortomesenteric left renal vein is slightly higher than that of the hilar left renal vein, 40 to 50 centimeters per second, versus 10 to 20 centimeters per second. We compared the peak flow velocities in Nutcracker syndrome patients and control groups and proposed diagnostic criteria of peak flow velocity of aortomesenteric portion higher than 80 to 100 centimeters per second, or more than 5 times the peak flow velocity of the hilar left renal vein. The simple and practical criterion is 100 centimeters per second peak flow velocity at the aortomesenteric left renal vein. This is an example of Nutcracker syndrome diagnosed with Doppler ultrasound. Color Doppler ultrasound shows compressed and narrowed aortomesenteric left renal vein with the bright colored jetting flow and peak flow velocity 182 centimeters per second. One question you might have is, what is the relationship between the Doppler velocity criterion of 80 to 100 centimeters per second and the pressure gradient criterion of 3 millimeter mercury? If we calculate the theoretical pressure gradient using this Bernoulli principle of continuity, this velocity criterion of 80 to 100 centimeters per second is equivalent to a pressure gradient between 2.39 to 3.81 millimeter mercury. So we may use Doppler ultrasound with this velocity criterion without invasive venous catheterization process in the diagnosis of Nutcracker phenomenon and Nutcracker syndrome. This is a young woman with gross hematuria. Grayscale and color Doppler show dilated hilar left renal vein and compressed aortomesenteric left renal vein and intermittent bright-colored jetting flow with peak flow velocity of 138 centimeter per second. And the estimated pressure gradient is 7.4 millimeter mercury. Many people told me that Nutcracker Doppler is too difficult. I believe two reasons they have difficulty are: number one, Doppler principles such as Doppler angle and sample volume were neglected, and number two, patient's comfort regarding patient's respiration was neglected. It is easy to get Doppler spectra from the hilar left renal vein because we have a nice Doppler angle in the neutral transverse plane. Is a clear spectra with peak flow velocity around 20 centimeters per second. But getting clear spectra from the aortomesenteric left renal vein is not easy and almost impossible in this neutral transverse plane because the Doppler angle is almost 90 degrees. We need to adjust the Doppler angle to get better spectra. To have a better Doppler angle, we rotate the transducer counterclockwise a little bit, and the aortomesenteric left renal vein within sample volume is located in the left corner of the image. But still, we do not have clear Doppler spectra, and the reason is sample volume of a few millimeters is too thin to cover moving aortomesenteric left renal vein between preceding arteries and with respiration. To solve this problem, we need to increase the sample volume thickness to 15 to 20 millimeter, and then we may get clear Doppler spectra like this with a peak flow velocity around 2 meters of second in this patient. Another example of nice Doppler angle and wide sample volume 20 millimeter with clear Doppler spectra with a high peak flow velocity around 150 centimeters per second, indicating a Nutcracker. Next thing we need to consider in Nutcracker Doppler is that we should make patients comfortable with respiration. This is a 36-year-old woman with foamy urine and glomerular filtration rate fluctuation. Grayscale and color Doppler show the Nutcracker phenomenon, narrowing and flow jetting. You may see a variation of Nutcracker findings with respiratory motion. These are Doppler spectra obtained with holding respiration in inspiration and expiration with different peak flow velocity 133 and 185 centimeters per second. Please note that the peak flow velocity in expiration is higher than that in inspiration. Doppler spectra are clear and show continuously same flow velocity because the patient stops respiration, but patients may have difficulty in holding respiration repeatedly. If patients are tired from holding respiration, it will be difficult to have the patient's cooperation. The best way to make the patient comfortable and to get nice spectra is to obtain Doppler spectra with the patient keeping shallow, comfortable breathing like this. And we see the respiratory variation, but we can measure peak flow velocity easily, which was 165 centimeters per second. This is another example of spectral Doppler with patient holding her breath. And this is another example of spectral Doppler with a patient keeping shallow respiration. This is an example of spectral Doppler without significant Nutcracker phenomenon, with the patient keeping shallow respiration and peak flow velocity being variable between 37.5 and 80.3 centimeter per second. Another technical tip for Nutcracker Doppler is not to compress too much to have a better ultrasound image. This is an example of the effect of compression with a transducer to the degree of left renal vein compression and the peak flow velocity. This was an old woman with epigastric pain due to a Nutcracker. The first set of the color and the spectral Doppler on the left side is without transducer compression, and peak flow velocity was 169. The middle set was with light compression, and the peak flow velocity was 213, and the last right side set was with strong compression, and the peak flow velocity was 324. There was a big difference between the peak flow velocities with different degree of manual compression with ultrasound transducer. The peak flow velocity with strong compression was almost twice the peak flow velocity without compression. We may check variation of Doppler findings with different postures, supine and left and right lateral decubitus, and may have an idea whether changing sleeping posture may work or not improve the patient's symptoms. A 25-year-old woman with microscopic hematuria, proteinuria, and left flank pain due to Nutcracker syndrome. In supine posture, a typical type 1 Nutcracker with flow jetting from the narrow aorto-mesenteric left renal vein with a peak flow velocity 214 centimeter per second. When the patient takes left lateral decubitus posture, superior mesenteric artery moved to the left side, and the left renal vein compression is much relieved, and the peak flow velocity decreased to 51.7 centimeter per second, a normal value. And when the patient takes right lateral decubitus posture, superior mesenteric artery moved back to the pre-aortic location, and the left renal vein is again tightly compressed between the abdominal aorta and superior mesenteric artery, and the peak flow velocity was 220 centimeter per second. She told me that her usual sleeping posture was right lateral decubitus, and I explained about the Nutcracker syndrome and the changes in Doppler findings with different postures, and recommended she change sleeping posture from right lateral decubitus to left lateral decubitus. And she came back to my clinic 1 week later with a bright smiling face and told me that her left flank pain disappeared. This case well illustrates the ability of a well-performed Doppler ultrasound examination in the diagnosis and also in the management of the patients with Nutcracker syndrome. Another similar patient, 60-year-old woman with microscopic hematuria and low abdominal pain due to Nutcracker syndrome. Doppler ultrasound shows similar difference in movement of superior mesenteric artery and a similar difference in left renal vein compression according to the posture changes. And her best sleeping posture will be left lateral decubitus, and her lower abdominal pain improved after changing her sleeping posture. In some patients, movability of mesenteric root containing superior mesenteric artery is limited, and Doppler findings are similar in all three postures. These findings may indicate adhesion or fixation of the mesenteric root, and changing sleeping posture alone may not work for the patient's symptoms. I usually explain the Nutcracker patients that the best sleeping posture is like this: left side down, semi-prone posture, hugging a long pillow, and ask them to avoid this flat supine sleeping posture. If patients' symptoms of pain or discomfort in some areas of the body disappear after changing sleeping posture, it is evidence that those symptoms were related to the Nutcracker phenomenon. Here's another patient with limited movability of mesenteric root and a similar degree of Nutcracker phenomenon with similar jetting phenomenon in 3 different postures. Another example of limited movability of mesenteric root and a similar degree of Nutcracker phenomenon with similar sluggish flow in the dilated left renal vein in 3 different postures. Classical symptoms of Nutcracker syndrome is gross hematuria, but more commonly, patients have microscopic hematuria or proteinuria and left flank pain. There may be various other symptoms or signs related to Nutcracker phenomenon. Many patients complain of foamy urine, sometimes with proteinuria, but frequently without proteinuria. Also, in many patients with the Nutcracker, they have fluctuating glomerular filtration rate, sometimes low glomerular filtration rate, and sometimes normal glomerular filtration rate. This glomerular filtration rate fluctuation is probably a result of different degree of Nutcracker phenomenon according to the sleeping posture. Sometimes Nutcracker patients have cystitis or BPH-like bladder symptoms, and many of those patients have pelvic or perivascular collaterals. Left flank or left back pain is one of the typical symptoms of the Nutcracker, but interestingly, many patients complain of vague pain or discomfort in various areas of the body, such as periumbilical, epigastric, subcostal, and inguinal areas, not only left side, but also right side. Many of those symptoms are related to developing collaterals. The biggest collaterals are through gonadal veins causing pelvic and perivascular congestion that may be related to various bladder symptoms and pelvic pains. Developing fine collaterals in the retroperitoneum or abdominal wall may be related to vague pains or discomforts in various areas, such as periumbilical, epigastric, and back areas. This was an old woman with cystitis-like bladder symptoms and hematuria, but cystoscopic findings were unremarkable. Ultrasound shows Nutcracker findings and peak flow velocity was 148 centimeters per second. Color Doppler of the pelvis showed severe pelvic congestion, which can cause cystitis-like bladder symptoms. This is an example of a Nutcracker patient with left flank and pelvic pain and urinary frequency. There was a Nutcracker phenomenon with peak flow velocity 118 centimeters per second, and the pelvic ultrasound showed severe left pelvic congestion that may be related to his bladder symptoms. Dr. Skolbacher in Germany mentioned that in the Nutcracker syndrome, there may be congestion in any part of the left half of the body from head to toe, and used the term midline congestion syndrome. This concept of midline congestion may explain various unusual left-sided symptoms in Nutcracker patients, such as headache, stuffed nose, neck, shoulder, or leg pain. This is still a not established but a conceptual syndrome and needs further clarification. This is a 42-year-old woman with microscopic hematuria and proteinuria. Grayscale ultrasound shows dilated hilar left renal vein and compressed aortomesenteric left renal vein, and color Doppler shows scanty flow signals indicating sluggish flow in the dilated left renal vein. In this situation, often it is difficult to measure peak flow velocity in the aortomesenteric areas because the amount of flow through the narrow to aortomesenteric left renal vein becomes small. Spectral Doppler in this case shows intermittent weak flow signals through the aortomesenteric left renal vein with peak flow velocity around 160. So sluggish flow in the dilated left renal vein indicates a severe Nutcracker phenomenon, and often there are prominent collateral vessels, most commonly pelvic collaterals like this patient. When there are enough collaterals present, left renal vein is not dilated but is collapsed, and practically most of the left renal venous blood flows through the collaterals, and almost no flow is detected through the aortomesenteric left renal vein, and the flow signals are difficult to detect, while slow flows with low peak flow velocity are detected, like this case. The Nutcracker phenomenon like this condition is called compensated Nutcracker, and these patients are usually female with prominent regurgitation into the gonadal veins and severe pelvic congestion. In this situation, left renal vein pressure is not high, and the patient usually do not have hematuria, proteinuria, or left flank pain, but have symptoms related to pelvic congestion. This is the summary. Doppler ultrasound is the best examination to detect Nutcracker phenomenon and diagnose Nutcracker syndrome. The two most important points you always keep in mind when you're doing Nutcracker Doppler are the first, Doppler principle, angle and sample volume. And the second point is the patient's comfort regarding respiration. Do not ask for too much breath holding to measure the flow velocity of the left renal vein, but do an examination while patients are keeping comfortable shallow respiration. Another point I want to emphasize is that the Nutcracker is not a fixed static condition, but is a dynamic phenomenon with posture and respiration of the patients. So please take maximal advantage of the dynamic capability of the ultrasound in Nutcracker Doppler. If you have questions or comments, please email me. Thank you.